colon cancer, more exciting topic. Tried to, I don't know, we have 30 minutes. So I looked at things that were on questions, and so some of it seems a little bit here and there, but maybe it'll be helpful for the test. So we're going to go over some statistics, because that's always what you start out with. And then and we're going to kind of go over some the surveillance stuff, because that came up again in questions when I was looking at colon cancer questions. And then again over sort of the familial things, and then operative strategies and other malignancies and kind of other funky situations with colon cancer. So this is in America in 2014, and 136,830 cases. It's the fourth most common cancer affecting both men and women. You know, I don't know if any of this really will come up. Median age at diagnosis 68. This is interesting. It's just that we have improved the incidence just with screening, and then with the screening we're removing those polyps, and so the actual rate, not the rate of detection, but the rate of cancer has gone down. So we all kind of know this, that most of the time people present without any symptoms. It's just from a screening colonoscopy or some sort of screening exam. But if they get to the point of obstruction and pain, then it's probably a pretty advanced stage. A palpable mass, it's interesting, even if it's an early stage when they're asleep on the table, you can kind of mash on them, and more frequently than you'd imagine, you can actually feel it, but you can't when they're awake, because they guard their abdomen. So this is kind of testable, like the sequence from just normal mucosa to having actually a cancer. This is the most common pathway. There's the sessile serrated adenoma pathway, which we'll talk about here, which is, depending on what you look at, this is probably about 60 to 75% of colon cancers arise in sort of the traditional one that we talk about, the two-hit hypothesis. And this is where it goes like from normal mucosa to an adenomatous polyp, and then a dysplastic polyp, and this is the tubulovillus and the villus and the tubular adenoma. That's that adenomatous polyp that we talk about here. And so the KRAS mutations, P53, two-hit, those are like the keywords that you see on the test. And these are some interventions that decrease the risk of developing cancer, and it's in there showing you at which step those happen. And I have had a test on this. So aspirin and NSAID, any like anti-inflammatory, can affect here at the APC site and at the KRAS site, and then going on to developing an adenoma. Anyways, and I thought it's estrogen because hormone replacement therapy can affect at the KRAS mutation site, decreasing the risk of continuing on to growing that adenoma. So you might, so it just doesn't continue to proliferate. So that's the more common pathway, the adenomatous pathway. The sessile serrated adenoma, the keywords with this, so it's a distinct pathway. You see on the pathology report enfolding of the crypt epithelium or sawtooth edges. Those are kind of the buzzwords. And this is activated through BRAF or KRAS, and the one that I kept seeing was in a MAPK-ERK in the colorectal stuff. This, like Samra even pointed out, because we keep seeing these questions come up on like the CSAP. So looking at, these are adenomatous polyps. You'll read also, it's like the sexy topic is the sessile serrated stuff, but all of the numbers differ depending on what paper. I couldn't even find the incidence of how many colon cancers come from the sessile adenomatous pathway. Like one said 5 to 8%, another said 20 to 30%. So I just said 5 to 30. So anyway, so we're going to concentrate on what we actually know more about, the adenomatous polyps. When they talk about the sessile serrated, this is probably what they're going to go after. So we just know that the bigger the polyp, the more likely the risk that it's a cancer. And in addition, the more villus characteristics, the more likely it is to be a cancer. So it's just kind of getting the idea of a trend. I tell patients that, it's like about, when it gets to about 1 centimeter, I say it's about a 10% risk if it's a tubular adenoma, because it mostly across the board it's that way, and it just goes up as high as 50%, depending on the pathology. One of the things I like about colorectal cancer and why I chose to do it is the staging is so easy, because it's none of this like complicated breast cancer sizes. Obviously if it's just in situ, there's not really an invasive component. It's stage 0. That's familiar with breast cancer. But this T1, T2 is 1, T3, T4 is 2, and then if there's any nodal disease, it's stage 3. And then obviously any metastasis is stage 4. So it's just, if there's nodal invasion, it's stage 3. Everything else is pretty straightforward. So it's helpful for my simple little brain. So obviously, like most cancers, any cancer, how well the patient does depends on what stage they are at diagnosis and when they start being treated for it. So very good. This is another reason I went to colorectal cancer surgery, because they have good outcomes. If we find it early, so if it's just like a T1, T2, it's a T2N0 cancer, they have a 90 to 95% chance of overall survival. That's in 5 years. That's so good. It makes me really happy to be able to tell people that. Stage 3, this is even with nodal disease. They, like 30 to 35 to 65. I always say I say almost half, 40 to 50%. I kind of stay in the middle when I talk to them. And I mean, that's with, invasion. And then, with nodal disease. And stage 4, not as well, but we're improving this. And we do have treatment options when they do get to stage 4. So that's something that's really satisfying, is that we can salvage those patients, and we can at least prolong everything and curb the advancement of that stage 4 disease. So interestingly, so prevention, high fiber, low fat diet, exercise has been shown to decrease the development of colon and rectal cancer. Obviously smoking and alcohol, but these are the ones that are kind of testable: the calcium and selenium, vitamins A, C, and E, and folate, and the hormonal replacement therapy, so estrogen and postmenopausal women, and NSAIDs. It's always the great debate. Are we going to give her all the other complications from her estrogen replacement, or we're decreasing her risk of colon cancer at least? Who knows? Secondary prevention, this is what's cool in colon cancer, is that with colonoscopy, with this great screening program that we have, we really do decrease the rates of colon cancer. And that's secondary prevention. I had a question about that, like, because to know what the term secondary prevention meant. And it's just, like primary prevention is decreasing risk factors. This one is detecting it early and addressing it. So screening, if that's something that you learn in medical school, like what are the situations that are ideal for screening for a disease? And colon cancer is a really good example of a disease that you can screen for. It's so a lot of people get it, so you're not going to screen the whole population for something that's like a 0.001% incidence, and that you can detect it, that it's asymptomatic at early, like you wouldn't screen for something that as soon as you got it, you knew about it, and that you can detect it at an early stage, and that you can actually do something about that early stage and prevent it from going on, opportunity for secondary prevention, and that you have a lot of time to find it, if it was like a 2-minute pre-cancerous stage, and you don't really have a lot of time to make a difference. But colon cancer is uniquely situated to do that. So risk factors, Crohn's disease, like inflammatory bowel disease, personal history or family history of cancer or polyps, and then the older you get, the more likely you are to have it. So high-risk patients, I think it's interesting that about 20 to 30%, so maybe even a third of the population is at high risk, is at increased risk. And And that just means, they might have a family member who has a history of polyps. And that's not that surprising when I go back and think about it. Like, a lot of people have a lot of polyps. And especially right-sided polyps make you a little bit more jumpy. And obviously any presence of symptoms, it's not determined to be a screening colonoscopy or exam. It's a diagnostic. But these are not patients so it's 20-30% of the population don't fall into those routine screening guidelines that we're going to talk about here, which is greater than 50 years old and colonoscopy, and you can do FLEX-SIG or FOBT. We went over those yesterday. But FOBT, or not yesterday, but last Monday, Tuesday. FOBT I had a question about this, that's why I put it up here, but it reduces mortality by 30%. This is from, I think, a Dutch trial. And we kind of poo-poo it because it's, but out in the community, it really is a good tool. And there's no data that says it's equivocal, it doesn't make a difference. And so it's very widely accepted. FLEX-SIG is a good screening modality because it's easy and it doesn't take very long. And in Europe, this is most of the colorectal stuff is out of Europe. And in Europe, they don't use any sedation for it. And we don't either here sometimes, but they don't even for some colonoscopies. They just get all the way around if the patient tolerates it. And so, it all goes up to the splenic flexure, and then, which is okay because in combination with an FOBT, which hopefully would pick up any signs of there being something on the right side, we're also double checking and looking to where the majority of polyps are. 67% are on that left side of the colon. We have some case control studies that show this is good, but no randomized prospective trials like the FOBT. And then colonoscopy, obviously, is like the gold standard. But in some situations, there aren't the resources to give colonoscopies to everybody. And so I think this is interesting that or is cost effective. It's more cost effective than screening and treating for high blood pressure, breast cancer, or providing renal dialysis. So the cost per added human year of life is the best for colon cancer, as opposed to like if you treat high blood pressure, you might not be that expensive to treat them, but it's over long term, and the number of lives saved, it doesn't really pan out to be as cost effective. Doesn't mean these are bad, but colorectal cancer, it's a great screening test. Isn't the root of it all. So we kind of went over, we did go over these last week, but the familial patterns to colorectal cancer, hereditary non-polyposis colon cancer, otherwise known as Lynch syndrome, and FAP. Again, it's autosomal dominant, about 5% of all colorectal cancers, and this goes along the adenomatous pathway. It does not go along the adenomatous pathway. And this is young patients with colorectal cancer. And these are the ones you'll see on the right side. And this is the testable information. Small bowel, bile duct, urinary tract, ovary. Endometrium is the most common other malignancy with HNPCC. And the Amsterdam Criteria, this is the one that most of the time you can get by if you know 3-2-1 rule. So 3 relatives who've had colon cancer, and at least 2 of them have to be first degree, and they have to be in more than one generation, so it can't just be all your siblings. And one of them has to be diagnosed at least before the age of 50. And it doesn't apply if you have FAP, because this probably would apply to you, but you have a whole other disease process that we know about. So you're at increased risk. You may not have HNPCC, but if you or a family member has 2 HNPCC related cancers, so if you have endometrial cancer, or like one person might have endometrial cancer and, well, I don't know, small bowel cancer. That's a bad example because small bowel is unusual, but maybe colon and endometrial in your aunt. Or colorectal cancer and a first-degree relative who's been diagnosed with colorectal cancer or HNPCC cancers, like the ones we were talking about here, or colorectal adenoma. So anyway, I mean, we could go there all ways. But early cancers, right-sided colorectal cancers at a really young age, signet ring type. These are all just things that if you see in a patient, you should say, oh, do I need to have them? Do I need to like sit down and go through their Amsterdam Criteria? So the HNPCC Genetics, it's difficult because we don't quite understand it. You'll have patients that are the perfect patient. Their whole family has had every HNPCC related cancer, and you just know they have it. You test them and it's negative. But that doesn't mean that they're at a normal risk. It just means that, first off, we probably just don't know that genetic mutation yet. But it's just very heterogeneous. But these are the ones that you see most. And that's why I say the MSH and the MLH is microsatellite instability. And so I remember those because they just kind of look the same. And then PMS I remember because it's OB/GYN malignancies are related to it. They're endometrial and ovarian. So that's just how it sticks in my head. And whenever we talk about, it's MSI, microsatellite instability, and DNA mismatch repair, autosomal dominant. These are like the buzzwords that come up. You have obviously an increased risk of colon cancer, an 80% risk by the time you're 65, as opposed to FAP, which is 100% by the time I think you're 50. And then if you have a colon cancer, and then later on down the road, about 30% of those patients are likely to develop another colon cancer. So, and endometrial cancer is the second most common, and about a third of patients will develop that of women. So maybe a sixth, if you think that way. And we went over this, but they love these questions. So patient with HNPCC, you start their scopes at about 20 to 25, about 1 to 3 years, and you're just looking for you're going to just keep doing those until you see the development of a polyp, and then you start screening, depending on what the polyp pathology shows. If they never develop a polyp, you can really stretch this out, maybe aim on the every 3 years kind of thing. And then again, the endometrial biopsy, they did an ultrasound and a biopsy at about 25 to 30. I just think 30 in my head. And then because it's associated with GU cancers, you need a UA for hematuria. It's an easy test. And then, so what do we do? What are the surgical options? It's for the most part, we can offer them a subtotal colectomy, which just means removing the abdominal colon. We'll leave the rectum. It's sort of a misnomer, but we'll anastomose the ileum to the rectum. So ileorectal anastomosis, meaning we don't go and take the whole rectum out. That's a big lifestyle change, and don't necessarily, because you can still screen that rectum. This is people who are have developed a colon cancer who we know have HNPCC, or they have a bunch of adenomas, and it's just a conversation with the patient. There's some patients that you wouldn't offer a total colectomy to, total abdominal colectomy. You think, you do have the gene, but you haven't developed any polyps at all, and you can kind of let them. And then the ones that and on the test, they're going to give you maybe a couple examples, and it's going to be clear the one that's the highest risk or the lowest risk. And then the hysterectomy and the BSO, that's a little controversial, but it's a lot of the major centers do offer it. I know here we have done it before, but it's not necessarily good or bad. Some people will try to argue that, we don't save any lives at all, but we're not sure. We're not sure with that yet. So FAP, also autosomal dominant. This one is less frequent, about 1% of all colorectal cancers, and I always think about that because it's a good thing, because it's the worst one, and so fewer patients have it. And this begins around puberty. That's why the staging, or the screening we'll talk about in just a little bit again, because we did it last week. And thyroid is the one that you see here, and we went over all that. And so this is the APC gene, 5q21. And so tumor suppressor, the last one was a microsatellite instability, and tumor suppressor here, buzzwords. And let's see. So this is also, it's not all family inherited. At least a third of them are spontaneous. So you may not have the the queue ahead of time to screen these patients. We went over this Gardner syndrome. It's the desmoid tumors and epidermoid cysts, osteomas, in addition to the FAP phenotype. And then Turcot's are those CNS tumors that we talked about, FAP. And frequency of hepatoblastomas, this one they like to test about. Thyroid, everybody's figured that out now, so they don't ask that as much. And then they can have retinal pigment changes. So this is, you just need to do an EGD, and we'll go, actually, let me just go to that. Well, so if you have done a total proctocolectomy, so you take out the colon and the rectum and you've recreated that, you did an ileorectal anastomosis, we make a pouch out of the ileum, we kind of fold it up on itself and make it into a J. Most of the time you can do it different, but the most common is a J pouch. And just because it's in the shape of a J, not because it's with the jejunum. I had somebody think it was the jejunum. But it's the ileum folded up and stapled, and then we anastomose that, and then it makes kind of a reservoir to mimic the rectum. It does not work nearly as well as the rectum. These patients have permanent changes in their bowel habits that can sometimes be debilitating. But sometimes that people do great, but it's not just a casual thing to do to somebody. And you have to screen. First off, they might have the tiniest bit of rectal mucosa left, and you have to continue to examine these patients for that. And you're also looking because they can develop polyps within that ileum, because as you can remember, there's polyps throughout the GI tract, even the upper GI tract. So I saw this in CSAP or something, but I hadn't really encountered it before. But protein truncation testing as a buzzword, it's a very good, sensitive, and specific test for FAP. And so this we already went over. You start there, a flex sig at 10 to 12. The reason it's a flex sig is you're just looking for the development of those polyps. Once they get a polyp, you start going all the way around. But this is a quick, easy test that's tolerable for a child. And then EGD starting at about 20, and you just keep following them up. And like I was saying, you need to check the rectum even after you've done a colectomy, and even after you've done a proctocolectomy. So in this, like the risk of their cancer is persistent even on into, like most cancers, the risk of developing a recurrence is at about 2 years. These aren't necessarily with cancer, but patients who have FAP that you've resected their colon and their rectum, 20, 30 years down the road, they might develop a cancer. So these are lifetime patients for you. So once somebody comes to you, that's sort of switch gears, when somebody comes to you and they have a diagnosis of colon cancer, you need to complete a colonoscopy. A lot of times they'll come to you with like a flex sig and a mass, and or they couldn't get up and all the way around. You really want to try to get all the way around because they might have a synchronous colon cancer or a polyp or something that you would have done something differently in the operating room. And then you need to look for metastasis, CEA. It's really a CEA and chest, abdomen, and pelvis CT. There's some question about whether or not a 2-view chest X-ray. The guidelines from the NC, like the National Cancer Institutes and and then the colorectal organizations, is that you get a CT of the chest. And then So for colon cancer, it's pretty easy. If it's left-sided, you take everything that from the left branch of the middle colic and then all of the IMA distribution. For right colon cancer, right colectomy, you take the ileocolic, the right colic, and the right branch of the middle colic. Extended means you take all of the middle colic from whichever direction. It just depends on where the tumor is. You want to get 5 centimeters of a proximal and distal margin on it. And then en bloc resection, bladder should be here too, and small bowel, which is there. So these are the things you'll see that I thought were unique questions. Obstruction, pretty much the same surgery, and if you can, a primary anastomosis. This is, I don't know why they said that in the book, but you sometimes cannot if they're really dilated, and you just divert them with the Hartmans. So synchronous cancers, this is like if you have something on the left and the right side, it's like the biggest pain in the butt. It's like a split when you're bowling or whatever, left and right. And so you just kind of have to bite the bullet sometime and do a subtotal colectomy with an iliosigmoid, iliorectal anastomosis. Because the question is, do you have 2 anastomoses? Most people would say no. And then cancer in a polyp, this is the Haggett's classification. Everybody loves that. Really, if you're going to leave it in, you need about a 3 to 4 millimeter. So if it's been resected and you're looking at the pathology, you need to go talk about it with the pathologist. And it needs to be like a T1 or TIS. And you need about 3 to 4 millimeter margin to leave the colon in place. So this, I've had this question before. If they have a AAA, you discover AAA when you're getting their staging workup. For the most part, you treat the AAA first. If they're symptomatic, obviously. The only difference is that if they're obstructed or they're bleeding from their cancer, you have to address that first. But you do retroperitoneal approach or endovascular. This is like an old thing for the aneurysm. And then cholelithiasis, if they have symptomatic cholelithiasis, it's okay to take their gallbladder out at the time. It doesn't really add much morbidity. And then the ovarian mass, I don't know why this was a thing. You take out the ovary. Pregnancy, I did have one question on this, and you just base it like every time on the trimesters, and you just aim your chemo for after or just consultation with the oncologist. So 5-FU leucovorin, FOLFOX for all node positive patients. You also find that if they were obstructed or they perforated, there's certain things, even if it's a T2, but they didn't have any nodal disease, but they were obstructed at the time of diagnosis, you might argue for adjuvant chemotherapy. No radiation for colon cancer unless it's invading the abdominal wall or something. That doesn't play a role like it does in rectal cancer. And this is stuff that's not very exciting. So yeah, most recurrences are within 2 years. Most commonly they occur in the liver, but they can be in the lung. They can recur locally, and you don't see them on colonoscopy. They recur extraluminally. So you have not excluded, really, if somebody's CEA starts rising, you need to get a PET or a CT, PET CT. So somebody's had a cancer, and then they have another colorectal cancer, that risk is 9% of developing another separate colorectal cancer. But they do just as well as they did with their first one, stage for stage. And then we'll go over this next week. Okay. And 30 minutes. Are we okay? Any questions? 7:30. 1.